You did arrive early. Welcome.
Hello.
Uh,
Boa tarde.
So, welcome. It's a bit early, but okay. Do you want to test anything?
Yes, I just wanted to see whether the sound was good enough.
Seems so.
It looks good. Okay, and hello. Me and I will share my screen.
Yes, please do. I'll stop my share.
Okay.
So that you can share your screen.
So this is this one.
Yeah, it seems perfect. You can put it on presentation mode as well.
Put it on the first slide. Let me check where's the first slide. Correct.
Perfect. Perfect.
Okay. So we start at 4 sharp.
Yeah, sharp.
And okay. So anyway, I don't move from here.
Okay. So if you want to leave this slide, we can already leave this slide, and instead of me showing,
it's up to you.
Yeah, you can.
I don't know what's the average attendance. I mean, for this webinar. I mean, live. I mean, when they're broadcast live. I remember that we were not that many for the last. I attended one of those. But what's the good news is that it's reviewed afterwards.
Yeah. Now with the holidays and all, we're having less attendance than other webinars in the past, meaning that we risk sometimes to have 20 people or something like that. On average, usually we have something between 30 and 40, and sometimes a little bit more. 60 or 70, it may happen as well. The only thing against you is the fact that we have just a week to announce the webinar. So usually we have a wider period, and it's a holiday.
We're in July.
It's holiday time, so
yeah, but I don't mind. I mean, as long as it's available on the website later on.
Yeah, it is.
That's the point. I mean, no, the only point is bad when it's live and when we have many people. We have supposedly more questions, but you'll see. We'll see what happens in the chat box and
exactly.
Yeah. Anyway, so I calibrated my talk about 15 minutes. Okay.
Yeah, that's perfect. That's perfect.
And we'll have 10 minutes for Q&A. Okay. Well, that's good. So I will mute and probably disappear for a while, and I'll be back perhaps 5 or 10 minutes before the webinar. Okay?
Okay, see you in a moment.
See you, Antonio. See you.
Well,
Hello.
Hi, Anthony. I would suppose that it would be wise to wait just a few more minutes for people to join, and
No
then
problem.
in 3 or 5 minutes we'll start.
Okay.
Giselle is calling you on the chat. Okay, so if you agree, we will start.
Okay.
Excellent. So welcome to this webinar that is one of the summer school webinars organized by collaboration between Euro-NMD and Treat-NMD. And I remind you that all webinars are produced by Euro-NMD, the European Reference Networks for Rare Neurological Disorders, ERN-RND, and by the European Academy of Neurology. Our webinar today is an overview of the current state of the art of neuromuscular disease management, and it's delivered by Andoni Ortiz Berea. Is a renowned French physician with certifications in pediatrics and physical medicine and rehabilitation, and a very heavy list of functions that he has and continues to have, namely the roles of medical director of IFM Teleton, general delegate of the Institut de Biologie in Paris, scientific director of the ENMC, and with the support of IFM is also contributed to the establishment of many myology worldwide networks. and you worked until 2019 as a clinical myologist in Hendaye, France, and as a deputy coordinator of FIONEMUS, the French Neuromuscular Network. Is recently involved also in the Middle East in collaboration with local researchers like Professor André Megar-Panid from Beirut, and he's co-founded the Maladies Orphelines Sans Frontières, an NGO that is dedicated to humanitarian relief in the field of rare diseases. So, of course, I've just said a few of the things that you've done, but I think that probably most of the people listening to you today just know you very well. So probably I didn't even need to say all these things, but thank you very much for giving us this opportunity to listen to you. And please, the floor is yours.
Thank you very much, Antonio. Muito obrigado. And so we'll move on to my talk. Yeah, I guess you can see my screen and slide.
Yes.
So this is my disclosures. Okay, so I basically work as a clinician and nowadays more as a teacher. Okay, I'm teaching biology not only in Paris but in various places in the world. Today we're going to address a great number of questions and issues. I'd like to show you the great diversity of neuromuscular disorders we're facing nowadays. We're obviously going to talk about standards of care, about their principles. We'll illustrate this with various focused standards of care, such as cardiac, respiration, orthopedics, nutrition, and health. And we will sort of decline some of the standards of care apply to various etiologies such as Duchenne muscular dystrophy, spinal muscular atrophy, and if we have time enough, others like myotonic dystrophies and congenital myasthenic syndromes. Just to remind you that the notion of neuromuscular disease is quite broad, but it's basically an impairment of one component of the motor unit, okay, by definition. The common denominator of almost all these disorders is paralysis, but this paralysis can be extremely variable in severity and in prognosis. They're usually regarded as rare, but they're not so rare, as we know, especially the most common ones, such as Duchenne or spinal muscular atrophy. It can affect both children and adults, and they're genetically determined in 90% of cases, as we will see. They're rarely curable, but sometimes they're treatable, and we'll see that because I think it's a major message to carry today to clinicians, is that times are changing. Okay, we're entering a new era in terms of therapeutics. So this is the motor unit. As you remember, the anterior horn cell, the peripheral nerve, the neuromuscular junction, and the muscle fiber. So each of these components correspond to some diseases, as we will see. These diseases are here, just listed, just to illustrate the great diversity of these conditions. You obviously remember the anterior horn cell disorders, such as spinal muscular atrophy, that we will address in a minute, ALS, spinal syndromes, etc. The nerve disorders, which can be genetic, such as the Charcot-Marie-Tooth disease and others. But they can be also acquired. The neuromuscular junction, emblematic autoimmune form of disorder is myasthenia gravis, but there's a small contingent of congenital myasthenic syndromes that we will study in detail at the end of the lecture. And finally, we have this quite heterogeneous group of muscle or primary muscle fiber disorders represented by dystrophies, such as Duchenne, limb-girdle muscular dystrophy, and so on and so forth, myotonic syndromes, and a mixed bag of miscellaneous disorders, such as mitochondrial, congenital, and so on and so forth. So again, this is extremely diverse. for clinicians, it's sometimes difficult to understand this diversity. And in terms of management, it's also a real challenge, because you have to obviously customize your approach to each of this disorder. I wanted to say that just to remind some of you that in the old days, the old dark days, I would say, we were in an quite obscure period of time. People knew nothing about these disorders. Every disabled child was labeled as CP, that is cerebral palsy or polio at the time. And when those disorders, I mean, the neuromuscular disorders were a little bit more knowledge, then every child was either a Duchenne or a Batten-Kaufman. There was no distinction. It was, again, a mixed bag. And more importantly, all these patients were sent home without guidance, without any standards of care at all. And obviously, because of this lack of consideration and lack of care, severe complications happened and led to premature death. Hopefully, and we'll see that, nowadays things have totally changed. Patients are properly diagnosed, accurately diagnosed. There are standards of care. These disorders now are more recognized in adults as well, which is quite an advance. And generally speaking, we observe a longer survival for all these patients, and probably a better quality of life. So just to illustrate this, and I just focusing on hereditary neuromuscular disorders, as you know, in 35 years time, we achieved a lot from the first discovery, 1986, of the dystrophin gene, responsible for Duchenne muscular dystrophy, to the situation nowadays in 2021, where we have approximately 400 different entities, corresponding to 600 or 800 genes or loci. The vast majority of these genes are known now, because we have NGS, we have very powerful tools to do that, and that's good news. And because of that, we now are exploring various therapeutic avenues, not only gene therapy, but also pharmacology, repurposing drugs, even cell therapy. Even I think it's a bit premature, but still. So there's a lot of hope, a lot of changes over the years regarding these disorders. This is just an example of this diversity. If you refer to this gene table curated by Giselle Bone and many others in the journal Neuromuscular Disorders yearly, then you will see this avalanche of new genes every year, corresponding to 800 different genes. Although we can argue and say, well, they include in the list, I would say, borderline disorders such as hereditary ataxias or hereditary paraplegias and other neuro-like disorders, I'd say. Anyway, so remember and keep in mind that we've been very excited by the advances made in genetics for the past 30 years, and that's great. We have accomplished a lot. But at the same time, we know, especially in adult people, that neuromuscular disorders can manifest as autoimmune disease, So they are acquired disease. And in that field as well, we saw a great number of advances to sort of delineate new disorders, new entities, discover new antibodies, and try to allocate each antibody to each type of clinical manifestation. So the field of immunology is very exciting as well. And as you know, and in terms of management, it matters a lot, that nowadays we can sort of differentiate the various dermatomyositis from the overlap myositis or inclusion body myositis based on the presence of antibodies, autoantibodies. And there's another group which emerged a couple of years ago called the immune-mediated necrotizing myopathy, with antibodies directed against HMGCR, which require a specific treatment again, and for which the prognosis has totally changed over the past 10 years as well. So again, immune-mediated myopathies have changed a lot. Similarly, and quite unexpectedly, I would say, the same happened for chronic immune-mediated neuropathies, the various symptoms that you know all well, CIDP, the motor multifocal neuropathy, and so on and so forth. And all this is advancing quite fast. And we recently had this notion, this novel notion of nodopathies at around the node as an emerging concept in those neuropathies. And again, in terms of autoantibodies directed against specific forms of the nerve, then we had also new tools which will help first diagnose the patient and second manage the patient more appropriately in terms of either immunosuppressants or corticosteroids. Now, when we focus on management itself, I just put this 10 commandments as key commandments for clinicians. Remember, the first priority is really to recognize if the disease you've been diagnosing is treatable or curable, but in other words, if we can really make a difference for you, for the patient. I think that's the key question, number one. Then, obviously, as you saw, we need to know whether it's genetic or not. And if so, we have to provide genetic counseling to avoid similar catastrophes in the family, for instance. And when it comes to treat the patient or to manage the patient, then you have to send it to specialists, because we know that for these patients, we have to be multidisciplinary, we have to be holistic, we say. And for that, there are referral centers, and we have to address this or to direct these patients to these centers for sure. And these centers will sort of dictate or advise for standards of care. And among the standards of care, there will be prophylaxis as well. I always say to be, as a clinician, to be empathetic to the patient, okay, because it's a long journey with them, okay, so you have really need to understand the sufferings and so on. And finally, you also have to prescribe evidence-based therapies, as we'll see. And this is another advance that we witness in the therapeutic field. In terms of interventions, and you see here that management and therapies are mixed, okay, together on the same slide, meaning that, okay, formerly standards of care were supposed to be just palliative care or supportive care, okay, something secondary, nothing to do with cutting edge therapies whatsoever. But nowadays, I think all these therapies are now part of the checklist, part of the management itself. When you see patients with DMD, for instance, with Duchenne muscular dystrophy, you will obviously talk to them about glucosteroids, glucocorticoids. You will talk about orthopedics, respiration, but you will also address the issue of atelurin or eteplirsen, oligos in general, and this kind of things. So again, at various stages of the pathophysiology of each disease, you can intervene, okay? And the mutated gene, for instance, here you can consider gene transfer, cell transplantation, even though the latter doesn't work at this point. You can work on messenger RNA, you can work on protein, you can work on beta physiopathology, and so on and so forth. Okay, so the message here is that all this has to be holistic. I always advocate for an accurate diagnosis for each patient, and I think it's key for management. Okay, you can't treat a patient if you don't exactly know what he has or she has. Okay, because we have, as I said and as I showed, there's 400 different entities nowadays. Okay. And the rule in the past was that there were many diagnostic odysseys. You know, people were just wondering for decades with the unspecific diagnosis of myopathy or limb-girdle muscular dystrophy, things like that. But nowadays, we really need to know what is the disease-causing gene defect, and so on. And for that, we have powerful tools, as I said. We have NGS, we can use muscle imaging, we can use the MSA, that's the myositis specific autoantibodies. And obviously, I used to say that you better fight your enemy once you've named it. Okay, so when you know precisely what was behind it, then you will find the best strategy to tackle the consequences of the disease. And having an accurate diagnosis is obviously a key point for genetic counseling if it's an hereditary disease. Again, for tailored care, tailored management, it matters too. And obviously for customized therapies based on the gene defect or on the specific autoantibodies you found. And finally, about enrollment into clinical trials, okay? You don't have a very precise and accurate diagnosis, you will never be allowed to enter a clinical trial. Just one slide to remind you that for clinicians, management is different in terms of age. In other words, pediatricians will have to face some diagnoses and not others, obviously. I've listed those who really manifest early in age, such as congenital multiple complex disease and so on, SMA type 1 and 2, Duchenne later on, and so on. So for this group of patients, when management is protocolized, we have guidelines nowadays. And if you deal with more aged people or patients with sometimes symptoms starting in adulthood or early adulthood or sometimes late adulthood, the situation will be totally different and the management rules will be different as well. Okay. As I said, the key priority is to identify a disease which might be treatable or curable in a sense. And for this, we have an ever-expanding list of conditions. I've put some of them here, for which we have now clear indications and clues to a specific treatment. Okay, so I will not comment all of them. I just added on the list a few days ago TTR, which is a genetic neuropathy, familial amyloid neuropathy, for which we have at least 2 strategies, 2 positive strategies, such as the RNA silencing RNase or the CRISPR-Cas9, which has been recently applied to this disease. And similarly for Charcot-Marie-Tooth disease, for which we were hopeless till recently, and where we found in a subtype called the SORD gene subtype, we can use an aldose reductase inhibitor to tackle the disease. Well, supposedly, clinical trials are in progress. So the message here is that, yes, we can treat perhaps a small number of patients, we could treat them, okay? We have new drugs and new therapies on the horizon, and that's very exciting. Now, standards of care. What are we talking about? Standards of care are principled. They're often based on expert opinions and more rarely in evidence-based medicine. In other words, because some diseases are rare, we don't have enough data or not enough patients to organize a real double-blind randomized clinical trial, for instance, for a specific drug or a specific intervention. And therefore, we have to base our consensus on what the best experts think, okay? So it's always questionable from a methodological viewpoint, but still, these expert opinions are valuable, okay? Again, these are just guidelines, recommendations, okay? They're not carved in stone. And they are more or less applicable because it will depend on your medical environment, the mindset of the population, the family structure, the local resources, of course, the insurance availability, the healthcare system. And as shown a couple of years ago by Jan Bernd Kirchner, which conducted a survey in Europe about the dissemination of standards of care from one country to another country. And there were so many differences. with some countries where those standards of care were almost not applied or differed quite significantly from the mainstream standards of care. And we should keep in mind as well that we need to update the standards of care on a regular basis, okay? Because there are, I think after 5 years, they are almost obsolete, or you have to take into account new drugs or new interventions, and this is a very dynamic process. So the standards of care usually advocate, and I think it's right to do so, a multidisciplinary approach. I think we all agree on that. It's not that always easy to organize, I must say. The second point I wanted to make is that it's more and more comprehensive. In other words, and as I said earlier on, standards of care are now more inclusive. Formerly, they were really focused on supportive and palliative treatment, but nowadays I think we need to include as well, from diagnosis to therapies, including registries, including the classical standards of care, but we really have to be comprehensive. And we know that there are emerging fields of interest in the standards of care, such as psychological support, emergency situations, obviously the COVID-19 pandemic. We incorporate in the standards of care nowadays therapies, clinical trials, outcome measures, which are a major concern because we're lacking good outcome measures in many disorders, neuromuscular disorders, I mean, including PROM, the patient-related outcome measures. Aging is now an issue, especially in Duchenne muscular dystrophy, when those kids, brackets, now reach 35, 40, 45 years of age. Standards of care are, as I said, holistic, but they need to be prioritized. And that's why I always say, let's look at the vital signs. And cardiac care, for instance, is number one. Otherwise, if you don't do nothing, your patient's going to die early. Same for respiratory care. It's an emergency. I mean, this is a priority care. The others are, in a sense, less vital. They're important too, but less vital. The second priority: nutrition, orthopedic care, and else. This is an example of customized management of the neuromuscular patient based on etiology. Okay, so I plotted here the various conditions and the various interventions that you can use, and you obviously realize that every patient is different. Okay, if you have, for instance, well, let's take SMA3. SMA3 may need orthosis. Yes, perhaps. Bracing, it's probably unusual, but it may, if it's a young one. Surgery, it will never be ventilated or tracheostomized, and cardiac care will never be an issue. Whereas if you have a Duchenne boy, then obviously orthosis will matter, especially in childhood. Bracing won't be an issue because we don't brace them anymore. Surgery, spine surgery, yes, certainly. Non-invasive ventilation, tracheostomy, yes and no, and we'll come back to that. So again, this is customized management, okay? And for each of the 400 diseases I mentioned before, we'll have to sort of list all these different types of care. Multidisciplinary, transdisciplinarity, yes, this is essential for better care. We need more and more specialists, okay, pneumologists, cardiologists, intensivists, genetic counselors, geneticists, and so on and so forth. But keep in mind, and that's why I enjoy this cartoon, is that you need a conductor for this orchestra, okay? You need a coordinator, you need the referral doctor or the treating physician, which is going to gather all the information from all the specialists and sort of digest it and will give it back to the patient and to the family. Okay. Otherwise, the responsibility will be diluted, and it won't be good for coordination. An example of the so-called National Neuromuscular Network, and I think they're very useful. Okay, that is this network of physicians interested and involved in neuromuscular or in management of neuromuscular patients. This is Filnemus, our national network of France. We're covering the whole territory, including overseas. Okay, and we've established national guidelines for a number of neuromuscular conditions. We have a specific program for people suffering from so-called diagnostic odysseys, okay, who have no or not yet an accurate diagnosis. And we have various multicentric committees at the national level, one for adults, another one for children, dealing with innovative therapies, for instance. Okay, so an isolated physician in France can't prescribe gene therapy in asthma, for instance, without approval from this multicentric committee. So that's very useful to work together for better care, for better coordinated care, and standardized care over the country. And the same is happening now at the European level, hopefully with the Euro-NMD initiative and others. I used to say that management of the patient, of the neuromuscular patient, starts with the diagnosis and the way we disclose the diagnosis. You know how traumatic it could be for both sides. I mean, for the patient, obviously, for the family, parents, and the physician as well. Okay, this is a very traumatic experience. We now have recommendations available. They've been written everywhere. So I think in most reference centers, neuromuscular reference centers, all this is well known and well conducted. It might not be the case in places where they're not used to this type of disorders. Again, the disclosure of the diagnosis has to be tailored to each individual situation. It's not the same disclosing a diagnosis of Duchenne muscular dystrophy or SMA and another diagnosis of myotonic dystrophy, for instance, or simple non-dystrophic myotonia, because the prognosis is totally different. Psychological support is often needed, we know that. And there are emerging topics within the disclosure of the diagnosis, such as the availability of innovative therapies, for instance, of SMA. Should we address this issue or this information to parents at this stage or not? That's always debated. And we have now a new issue with diagnosing pre-symptomatic patients. Okay, those who have been either screened early in a family survey, for instance, or because they have been screened by newborn screening programs. Yeah, and again, this will give rise to other issues and other debates and other recommendations, as we will see. So I said that I was going to illustrate a few standards of care, and we'll start with the cardiac standards of care. Okay. As you all remember, heart is a complex organ made of muscle. That's true. Okay, the cardiac muscle, but there's also an electrical tissue called the nodal tissue, and that's why we have a variety of phenotypes associated with cardiac disease. Here, and this is thanks to Karen Wabi contribution, we know that some neuromuscular disorders are at risk, and more at risk than others, to develop either cardiomyopathy or electrical diseases. Okay, and you can see them here: Duchenne, laminopathy, Desmin, and so on and so forth for the cardiomyopathy side. And here you see the other genes like myotonic dystrophy or laminopathies and so on, responsible either for conduction defects, ventricular arrhythmias, or supraventricular arrhythmias. So again, we have to adjust our management to this variety of symptoms and signs, because the consequences are totally different. And cardiomyopathy, the main risk is heart failure, okay, chronic heart failure. And if you have an electrical disease, then your risk is sudden death and obviously stroke, okay. So again, it's not always clear cut, because in many neuromuscular diseases, you may have a combination of the two, okay, heart failure and conduction defects. And again, you have to customize your care according to this distinction. Okay, and again, this is now pretty well standardized that you should screen for both, I mean, the cardiac function first and the rhythm disturbances. And for that, you will obviously need some investigations on a regular basis, and you can intervene, and that's the good news, and that's part of the cardiac care in these conditions. So again, this is just a summary where you see the various neuromuscular conditions at risk of having heart disease in general, okay? Keep in mind that you should distinguish between left ventricular dysfunction and this conduction defects. And at the end, you may have an arsenal of either drugs, such as ACE inhibitors, beta blockers, diuretics, antiarrhythmics. You can use pacing devices, just as a simple one, regular pacemaker, an ICD, implantable cardiac defibrillator. Even more sophisticated is the assistive ventricular device. And ultimately, if you're really not coping with the heart failure, then you may propose your patient for a heart transplant. And that's been done in neuromuscular diseases, believe me. Second example of standards of care is the respiratory standard of care, okay? So you probably remember all this. It's a matter of inspiratory muscle weakness combined with expiratory muscle weakness, upper airways dysfunction, leading to not only alveolar hyperventilation, but also cuff failure and swallowing impairment. And all this leads and results in respiratory failure. We know how to investigate all this now. We have nocturnal ventilation, looking for apneas and hypopneas, and looking for alveolar hyperventilation. We can look for symptoms, but symptoms are usually mild. I mean, they are not correlated that much with the degree of impairment. You know, the cuff process, again, this is a very complex phenomenon, but most pulmonologists know how to tackle this and to help the patient to cough more positively and efficiently. Again, we have investigation. I think the vital capacity remains the major key outcome in respiratory care. But in addition to that, you should also rely on non-invasive inspiratory muscle ventilation, the sniff test, or maximal inspiratory pressure. So again, we have tools for that to measure how the patient breathes. Same for maximal expiratory pressure or the peak cuff flow. All this is simple. You need machines, but they are usually simple machines. So again, when you find that, and this is just a symptomatic treatment, inspiratory muscle support will require probably mechanical ventilation at some point in time. And when you have expiratory muscle support in the sense of cuff system techniques will be very helpful. There are still some arguments about when to ventilate, not too early, not too late, based on symptoms, certainly, but doesn't help always, or just on following criteria shown here, such as the high level of dioxide in your blood, and so on and so forth. We now have made a lot of advances in interfacing between the patient and the machine. Okay, you know all those masks available now commercially. There's a trend nowadays to use, especially in Duchenne aging patients, the mouthpiece ventilation, which is quite convenient, in addition to nocturnal ventilation, which might be nasal. Tracheostomy, well, the use of tracheostomy varies much between one country to another, as shown by this survey in 2005. But the trend nowadays is that we do less tracheostomy in general for neuromuscular patients, preferring non-invasive ventilation for sure. And that's what we observed. So the rare indications for tracheostomy are when your non-invasive ventilation has failed, yes, certainly. When you have major swallowing disorders, yes. And if an acute respiratory failure, you can't wean a patient from the ventilator, again, tracheostomy might be required. Okay, so it's nowadays a limited number of indications. And why is it so? Because tracheostomy has some complications, okay, and they're not minimal, let's say hemorrhagia, mechanical trauma, and so on. And that's been studied years ago. It's well known. Okay, but when you look at the survival, there's no demonstrated difference between non-invasive ventilation and tracheostomy in terms of survival. Even in terms of quality of life, that's not much difference. So it actually depends much on the feasibility and on the patient's wishes. Again, for mechanical, cuff assistance, we do have machines now. We have also manual exercises that can be applied by the physio, and all this is being standardized and available in most places. These are just machines and devices used by the physios or by parents themselves to clear secretions from the upper airways. So these are just a summary of the respiratory care nowadays in the context of neuromuscular diseases. Just a few words about orthopedic care. We know that the key issue for these kids and adults is about contractures and what can we do for that. Okay, positioning is important, stretching from an early age, always passive, better than active, and so on. You know all that, but that's key. I mean, that's essential, especially when the child is growing. Okay, if he's not stretched, he may develop contractures and limb deformities. Splinting, yes, it's certainly useful in many instances, especially in kids. Adjunctive measures, yes, hydrotherapy is certainly very good in most patients with neuromuscular diseases, and so on and so forth. Now, when it comes to spine surgery, it's another story, because it used to be a very traumatic and hazardous intervention years ago. Hopefully nowadays we're doing much better, we're doing much quicker, and it helps the patient to stand by himself, in a sense, straight up, instead of being full of contractures and having a major scoliosis. Okay, this is just an example of what we do now. This is for SMA type 2 patients. We can use rods, insert them surgically, and extend them over time. So we'll script that. And okay, so just to finish, I gave you the general principles of cardiac care, respiratory care, because they're essential. Okay. Now, what about applying this care to various etiologies? Okay, let's start with Duchenne muscular dystrophy. So you all know the disease. It's a devastating disease leading to wheelchair by age 12, sometimes earlier, respiratory dysfunction and cardiac dysfunction leading to premature death. So the management of Duchenne boys have been standardized many years ago, 2009 already in the Lancet Neurology. You'll see again this multidisciplinary team around the patient, and we had guidelines for each topic or each field of interest: respiration, cardiac, so on and so forth, gastrointestinal issues, swallowing, psychological management, and social. These guidelines have been revised, okay, not long ago, 3 years ago, and they've addressed more fields, covering now, as I said, emergency management, psychosocial care, transition from childhood to adulthood, which now becomes more organized in many centers. So that's basically what I said. I will skip this and just perhaps one word about glucocorticoids, because in Duchenne it remains gold standard. Okay, it's cheap, well, in most places, but we still have many questions about that. Okay, what's the best regimen? When to start? When to discontinue? Could we use this with other therapies, emerging therapies, such as oligos or Etelurin? So there are still questions, there are protocols, there are surveys about that, but I think reaching consensus seems extremely challenging over the years. Okay, so if you're interested in this topic, I think you should refer to this very important and interesting paper that was published a few years ago. So the supportive treatment, as I said, management only, and that has been said by Kate Bushby many years ago, that Duchenne is a treatable disease. But using this simple protocol, home ventilation, steroids, spine surgery, prevention, AC inhibitors, perhaps to prevent cardiomyopathy, then you will gain many years of life for your patient. That's been proven now. There's no question about it. And that's a reality. And we're not talking about emerging therapies at all. We're just talking about supportive treatment. So there's sort of a consensus nowadays for these kids. This is just what we're doing in France, but that might be slightly different in a neighboring country. There's guidelines and management recommendations have been published in various languages, and that's excellent. I talked to you about the problems of aging, not only physicians, but in patients as well. Now, Mathieu, shown here, is now 43, is a Duchenne, a genuine Duchenne boy. He's no longer a boy, he's now he's a man. And he's in his 43 years old. That's very fascinating. Anyway, I'll skip that one. Standards of care in spinal muscular atrophy. It's another example where things have been protocolized. Again, we'll see the same multidisciplinary approach with the patient at the center. There are guidelines that have been published, that have been revised, and they have been widely spread. Patient organization played a key role in disseminating the information for the members, and that's good news. But again, because of the emerging therapies in SMA, the standards of care will certainly change, okay? Because we are now dealing more with, I would say, type 2-like patients. I mean, the type 1 patients which survived, which probably improved a little, but still, they need care and multidisciplinary care. And we'll probably observe what the so-called new phenotypes in the near future. So again, the standards of care have been published. They have been revised in 2017. And again, they're trying to cover all the fields, okay? Medications, supplements, nutrition, immunizations, and at the time of COVID, that's an important issue. Ethics, we never talk about ethics from the beginning of this talk, but I can tell you that's becoming a major concern in some situations, especially when you deal with gene therapy or when you deal with discontinuing an emerging therapy in an SMA kid. That's an ethical problem for sure. So again, this is just an example of consensus. We've reached at least in France for SMA type 2 patients where we perform physiotherapy, spine surgery, or spinal fusion at some point in time, combined with assisted ventilation when needed. tracheostomy. If we can avoid tracheostomy, it's always better. Okay, that's respiratory care, but I mentioned this. In SMA, I think the most difficult thing is about orthopedics, okay, because it requires an expertise which is not available everywhere. And this is the corset gauchois that we use in France, which is probably the best corset for this situation, where you can also use orthosis adapted to this brace. And surgery in spinal muscular atrophy is also a major concern that you can see here. Nowadays, we can use rods. We're trying our best, and we're now tackling most of the scoliosis in these patients. But again, things are changing because they're now treated by either nusinersen or gene therapy. So what is going to happen in their back, in their spine, we still don't know. Standards of care in myotonic dystrophies. I will probably skip that one for the sake of time, because I'm a little late. But just to remind you that we have two sorts of myotonic syndromes, okay? The dystrophic ones and the non-dystrophic ones. And what I will address now is the myotonic dystrophy type 1, which is Steiner disease. As you know, it's quite prevalent, especially in adult patients. There are all sorts of complications because it's multi-system disease, and you need multi-experts in your team, respiration, sleep specialists. Surgery, it's not longer an issue, but eye surgery, cataract surgery, yes, is an issue and so on. Okay, so because of that, again, the multidisciplinary approach is extremely important in this condition. Gastrointestinal, swallowing disorders, yes, endocrine issues, infertility has been described in this disease and needs to be addressed. We all know that. And this is the clinical management rules for myotonic dystrophy type 1. Again, multidisciplinary, cataract surgery, heart intervention, and they can be life-saving interventions such as a pacemaker or ICD. Exercise might be useful. Metformin has been shown by a few groups to be effective in this disease. And we have recommendations either published in the USA and being either adapted or adjusted to the European context. Okay, another example of standards of care for one specific group of diseases, and this is the CMS, the congenital myasthenic syndromes. So you remember it's myasthenia, but it's a congenital one. In other words, there's a family history in most cases, and there are various genes involved, almost 20 different genes. And interestingly, we do provide supportive care for these kids, okay, such as respiratory care, orthopedic care needed, nutrition, cardiac care, etc. But more interestingly is that since we know the different genes responsible for CMS, we can adapt the regimen of each drugs for each subgroup of myasthenic syndromes. And one important message, for instance, is that in at least 3 of them, such as DOX7 and the acetylcholine receptor esterase, that is ColdQ syndrome, you should avoid, for instance, the current and classical treatment with acetylcholine esterase inhibitors. Okay, so that's an important message. You can sort of adapt your strategy. Okay, and I will skip that one for the sake of time, just to sort of elaborate on the take-home messages for this talk. I do think we have nowadays more standardized, more comprehensive, and more global care or set of recommendations, okay? And that's the product of 20 years, 30 years of consensus or of attempts to find a consensus for each disease and for each subtype of each disease. At the same time, keep in mind that all this has to be customized. Every patient is different. even within the same subgroup. A Duchenne boy is probably different from another one, and vice versa. Now, the big question is, would this accomplishment be jeopardized by the current pandemic? And it's an open question. I have no answer. I could have told you about what has been done to keep this multidisciplinary care for these patients, but we know that in many countries it's total chaos. Clinical trials have stopped. Patients don't want to go back to the hospital, and so on and so forth. So how long will this last? We don't know. At the same time, that's the flip side of the coin, and that's the good news. We're just seeing now a tsunami of novel therapies on the horizon. Okay, we're just at the very beginning, and the list I showed you before will probably expand over time. And finally, I think management of neuromuscular patients illustrates the importance of networking. Okay, not only at the national level, but also at the supra-national levels. An initiative taken by Euro-NMD, but also Treat-NMD and in other places in the world are very encouraging. And finally, I'd like to acknowledge the Euro-NMD, my colleagues from the AFAM Teleton, and all these parents and families which suffer daily from these disorders. And now I'm ready to take questions. Thank you very much to all of you.
Well, I think that it is our role to thank you. This was an impressive and comprehensive description of many of the aspects that make the care of neuromuscular patients so complicated at the same time. We don't have at the moment any questions on Q&A, but I want to say to anybody that talking is permitted for everyone. So if you have any question, you can unmute yourself and talk and voice the question. In the meantime, to, as usual, put people at ease and comfortable to put questions, I will start myself, if you don't mind. Of course, as you imagine, we choose our questions difficulty according to the experience and expertise of the lecturer. And today I'm going to use my extra difficult questions. So don't count on easiness from my side, sorry. Because the first one is when you have a patient, and I think that is often most acutely felt if you have a pediatric patient. What the parents want is a cure, it's not treatment. So we start to have some promises of cure for a few cases in each of the diseases. So as you understand, when people listen to gene therapy results on the television or social media, they don't care about the variant that affects the loved one. They care about the fact that there is gene therapy. So although I understand that to learn how to do this management of expectations from the patients and the family is something that we need to go shoulder to shoulder with you and watch you work basically on a daily basis. But apart from that kind of tutorial that we cannot give by these means, what can you say about your approach to that management of expectations, and how do you prevent people from being basically disappointed or depressed in view of the real scenery for each case?
Well, I think that's the most difficult challenge we have as clinicians. I mean, to finally tune what we have to tell the parents in terms of necessary care and hopes, okay? All this should be balanced, of course. It will also depend on the family itself. You know, sometimes parents are quite knowledgeable about the disease, about what is expected. And that's why I mentioned the fact that all these recommendations, including therapies, have to be customized and depends on the mindset. I think the mindset is essential. Now, how can we tackle this difficulty? Most probably, I think, by using the information channel by, as you said, because you mentioned the social media. And I had in mind the patient organizations, okay, which know exactly the fine and appropriate tone to use the families. And they are very useful to explain to the newcomers to the field that, of course, we have hopes, reasonable hopes, for instance, for Duchenne and for SMA, but at the same time, they should keep on following recommendations in terms of care, daily care. I remember that sometimes they say, well, my kid will never need a spine surgery, for instance, because gene therapy will be available next year or so. But that we don't know. And so we have to prevent them from dreaming too much, but at the same time, we can't prevent them totally. I mean, it's not human. Mm-hmm. So for a physician, another point is the, probably I didn't tell it before, but when we meet with the various clinicians, okay, in these committees, national committee for SMA, and when we discuss the indications of each new therapies versus even palliative care or termination of care, of treatment, then when this decision is made by a group, our experience is that it's much better received by the family. And that way they will not think that, oh no, my kid was not eligible for gene therapy, for instance, because I met the wrong doctor. No, if the decision is collectively taken or made, this will be more accepted. But again, it's a very difficult issue, I recognize.
Terzinha has a question, so go ahead.
Hi, I don't know if you hear me or not.
Yes, we do.
Speak up a little.
Speak up here.
Okay. So if we are in the difficult ones underneath, so I'm going back to SMA and adult forms of SMA. What do you think that should be the criteria to stop and to start current medications? Do you have any idea, any point of view regarding, and I'm talking about SMA type 3, the adult forms.
Well, so your question is about discontinuing treatment, right?
Starting and discontinuing. Do you think you start to all patients?
Well, again, the notion of consensus is sort of unrealistic because by definition, we always discuss these cases one by one. There's obviously a general rule given by the EMA about the indications and the label for each drug, but the decision is made by the committee based on the individual situation and so forth. That's just to start the medication, okay? Now, to discontinue the medication, we all think it's a situation that will come very soon for SMA patients. Let's say in 2 or 3 years' time, after having 40 lumbar punctures, some of them being very painful, and when the benefit will be assessed for them, and even by themselves, they may realize that it's not worth it. So either they will ask themselves to discontinue the treatment. It happened already. I know that. On the other hand, the worst situation is when patient may cling to the treatment, you see, saying, and despite the absence of any improvement, clinically objectable, okay, where there's no improvement of the markers didn't show any improvement, but still the patient wants to have it. And for that, we'll certainly have to argue with the family first. And again, if the decision is made collectively, I think it will be more accepted and more acceptable. But you know, this is not specific to SMA. The same happened to Pompe disease, or the early onset form of Pompe disease, when after many years of treatment, parents were really fed up with the treatment. But we need more time. I mean, we need more data. We need more feedback from families, from patient organizations. We need more scientific papers. Yeah.
Yes, well, we could go on forever. I would ask you, for instance, how do you convince the current hospital administrators to allow a multidisciplinary approach to patients, because basically what they want is that you see 6 patients in an hour and the rest is not of interest for them.
Okay.
But do you want to answer that one? Otherwise,
well, no, but I think you're right to raise this point, Antonio, because as I mentioned, multidisciplinary approach is kind of a luxury that some facilities can afford and others can't, definitely. And sometimes you have to be I used to say yourself as a unique physician taking care of this group of patients in a given hospital. You have to be by yourself multidisciplinary. In other words, you need to know everything about everything and trying to prescribe and perhaps get the opinion from other colleagues. But basically, you'll be the conductor and the best multidisciplinary professional.
Yeah. And you'll lose the advantage of having several heads responding to the patient and family, and you lose basically the multidisciplinary look, even if you're doing it. So I've known that situation in the past, as you imagine, and probably most of us. Okay, so I don't know if anyone has any burning questions still. If not, I'm going to finish and start by thanking very much Andoni for his marvelous presentation and for the useful discussion, and remind everybody that even if you want to re-see it or to recommend this lecture to anyone, that it will be made available through the Euro-NMD website on the webinars division and through our YouTube channel very soon. Okay, so thank you very much, and hope to meet you soon.
Okay.
Bye now.